Well, ladies and gentlemen, a very good evening to you. I trust you enjoyed your dinner, especially that banana caramel mousse, which apparently the chef fondly refers to as diabetes in a cup. It is not easy getting old. It's, thank you for that. It's made a lot harder when someone greets you and goes, "Hi, Dr. Mole. Wow, your hair color matches your suit." It's like, guys, really? Hope your night started better than mine did. In fact, just the other day I was in a lift alone, and a beautiful young woman steps into the lift. She's on a phone, and she says to the person on the other end of the phone, "Excuse me, gotta go, cute guy in the lift." My day is made. Then she looks at me and she goes, "Oh, sorry about the lie, just had to get off the call." Just horrible. Yeah, getting old is not easy. But Jean-Louise Calmar, a lady, the oldest documented lady ever to have lived to 122, died in August of 1997. A fascinating old lady. She grew up in France. She remembered the Eiffel Tower being erected. She remembered a mean old man coming to buy paint from her father, a man called Van Gogh. She rode a bike until the age of 100. She quit smoking at the age of 115. Felt it was becoming a habit. But on her 120th birthday, they had a big celebration for her, and she said some fascinating things. She said, at 120, I realize I have no peer pressure, which, okay, we get that. She also had a lovely sense of humor, and she said, I've only got one wrinkle, and I'm sitting on it, which was just too much information at the time. But then she made this statement, which fascinated me. She said, if I could live my life over, she's 120, if I could live my life over, I would trade a long life for a good life. What she would say in today's terms is, I choose health span over lifespan. I mean, Tithonus made the same mistake in Greek folklore. Apparently, Tithonus went to the gods and asked for eternal life. They granted him eternal life, and he was overjoyed until he realized he should have asked for eternal youth as well, as he just got older and older and older and older. Health span, lifespan. The average lifespan of human beings today is around 73. The average health span, as you guys would know, is 63. 63 good years without disease or disability, and then the wheels come off. And I suppose the question I want to pose to you is the first ethical question for the night is, should we as healthcare practitioners even be thinking about extending lifespan, or should we be focusing only on health span and narrowing that 10-year gap? Just a thought. Good evening, and a very warm welcome to Melomed's Ethics CPD event. It's wonderful to have you here tonight, our esteemed colleagues, our guests, our friends, all our healthcare practitioners. Really looking forward to a very, very special evening. On behalf of Melomed's directors, their executives and management, it really is my privilege to welcome you to tonight's vital conversation. And it is a vital discussion. Medical ethics shapes how we practice. It determines how we care for our patients. It determines how we make critical decisions. It really is key, not just for the points we're going to get for ethics. It is an important conversation to be having. So to Melomed again, thank you for taking this initiative in hosting an event like this. Health span versus lifespan. Good question. By the way, the average lifespan of South Africans, again, you guys would know this, is 64. All right, just wanted to put it out there, which means if you're 64 or older, you're living on borrowed time. Sorry, I didn't mean to look at you, Dr. Patel. You just happened to be kind of in my line of sight. The other thing about 64 is the birth control pill celebrates its 64th anniversary this year, which means if you are 64, not only are you living on borrowed time, but there's a chance that your parents didn't want you. So just kind of putting it out there, guys. 64, not great. Before we begin, though, I'd like to acknowledge, again, just and say thank you to the Melomed leadership team who really have made this event possible. Just met our esteemed chairperson, Mr. Ibrahim Borat. Thank you so much for having us tonight, as well as one of our dedicated directors, Mrs. Zohra Borat, and of course our chief executive, Mr. Ishmael Borat. Let's give them a big round of applause. Thank you so much for hosting us tonight, guys. We are also privileged to hear from three exceptional speakers this evening, all leaders in their fields. I'm going to introduce them to you when their chance comes up to speak, but we also want to encourage you to engage with our I was going to say exhibitionists, but that's probably not a great word. Our sponsors and our individuals that are exhibiting in stands at the front of house, please engage with them and enjoy some of the innovations and solutions that they are displaying that are shaping the future of healthcare in our country. I love innovations. In fact, sometimes innovations and inventions are so old they don't feel like inventions anymore. At the turn of the century, in the early 1900s, men only wore collared shirts that buttoned up. The problem with buttoned up shirts was that you lose your buttons. And back then, men didn't sew. In fact, today, men still don't sew. But back then, if you lost a button, it was a problem. If you didn't have a mother, a girlfriend, a wife, or a sister, you didn't have anyone to sew on your buttons. And so a very clever underwear company launched a very innovative new product. It was a shirt that they marketed to bachelors as a shirt that required no needle, no thread, no buttons, and it was stretchy enough to be pulled over your head. They call this innovation the T-shirt. Isn't that cool? T-shirt is a 120-year-old innovation. It doesn't feel like that anymore. But the T-shirt. There's one more innovation, and then I'm going to hand you over to our first speaker. Dr. Walter Halstead was an American pioneer in 1894 who fell in love with Caroline Hampton, the head nurse at Johns Hopkins Hospital. Caroline developed some blisters on her hand, contact dermatitis because of the disinfectants, the harsh disinfectants used in the operating room. And so Dr. Halstead went to the Goodyear Rubber Company and asked them to kind of create or innovate thin rubber gloves that he could give to the love of his life to protect her hands from these disinfectants. They were such a hit in theater. Surgeons wanted them, other nurses wanted them, and it turns out that little act of love, the rubber glove, just turned infection rates on its head and revolutionized surgical hygiene just because of a romantic gesture between a doctor and his nurse. So love conquers all, even germs. That's an innovation for you, that latex glove. Next time you put it on, think of that story. I've said way too much. Let me hand you over to the reason that you guys have come tonight. Our very first speaker is head of the Benefits and Risk Department at the Board of Healthcare Funders. He has a rich background in both clinical practice and the healthcare industry. Dr. Patel has held roles ranging from family physician to medical advisor, scheme manager, and clinical risk manager. His passion, though, lies in quality assurance, values-based medicine, and applying public health principles to health risk management in the private sector. He serves on the Health Data Ministerial Advisory Committee and has held key positions with the Council for Health Service Accreditation of Southern Africa, as well as Health Quality Assessment. For those of you who know Dr. Patel, he says, "Don't call me Dr. Patel, my name is Rajesh." And we like that about him. We love the humility. Tonight, he's going to be sharing his insights on NHI implications for health professionals, which is why we had dinner first, in case you lose your appetite after his presentation. Let's give Rajesh a big round of applause. Thank you very much.
Thank you very much. In fact, when my kids were small, about 7 years old, she said I'm not a real doctor because she never saw me in a stethoscope. Yeah. Today's talk is about NHI. Let me put my disclosure up front. That might influence where I come from. Okay. That might influence sort of where we come from at BHF. We've actually taken the president onto court to explain how he signed the NHI bill into the act. But really, today it's about yourselves and how this NHI is going to impact you. Normally, when I do this talk, it's usually about 1.5 hours, but I don't think the facilitator and the chairperson has allowed me that time. So we're going to do a short version. Initially, we're going to start off with universal healthcare coverage, what it actually means and some of the implications of that. You often hear these terms thrown around: universal healthcare coverage, NHI, etc. So I thought we'll do some clarity on that component. The three components to universal healthcare coverage. This obviously comes from WHO. The one is to increase the number of lives that are sort of insured or protected for access to care. From your perspective, it might look at it from a perspective of increasing your patient base that you have to cover. The second component is the benefits that members enjoy or the services that's delivered. From your perspective is looking at the skills you have. If you're a primary care practitioner, There's a whole big scope and the extent to which you can do all those procedures, services to offer members. I know these days in the urban environment in Joburg, many of the doctors don't do circumcisions, abscesses, wound suturing, those side room procedures type of thing. And a lot of people have been de-skilled. Potentially in an NHI environment, that might be part of the scope of practice that's expected of you, so you might need to reskill yourself. So that's an important component and implication from a UHC perspective on yourself. The last one is obviously financial protection. If you look at it from the medical scheme perspective, obviously there's one component which is what they pay. The other component is the out-of-pocket payment that people experience either because they've exceeded their benefit or because of the charges of providers. This is obviously your role. At the end of the day, you charge fees, and that might determine the out-of-pocket payment that they do experience. So that's a critical component to think about. That more or less in a nutshell are the three important components of universal healthcare coverage. So when people are using the term universal healthcare coverage, this is what we actually talk about. But then there's the NHI. You often hear some of the people talking of NHI as if it's UHC, and they're talking about UHC, they're using the term NHI, and sometimes they use the term NHI as if it's the whole health system. So I thought for this session, we'll start off by giving you a sense of what the health system is. According to the WHO, it's made up of those 6 blocks, starting from service delivery, health workforce, health information systems. The one that says access to essential medicines, but it's the whole sentence reads access to essential service, essential medicines, and essential vaccines. Then you have financing, I think they said health information system, and finally the last one is leadership and governance component. When we talk NHI, it's specifically related to this financing only. It's not the health system. So in February, when the Minister of Finance said we're allocating 1.2 billion for NHI, it's not NHI because the act wasn't even passed at that point in time. It was more for the health system strengthening. Right across from service delivery, improvement of that, improvement in infrastructure, extra workforce, information system development, etc. That's what they were referring to. It's all things that they should have been doing over the last 20 years. NHI just came into act now. The minister, our president still has to proclaim it before any actions or implementation can start taking place from there. What's happening here? It's not working. There we go. So just a little bit of provider distribution for NHI, and to give you a sense of what the distribution looks like between the public sector and private sector and some context. Obviously, in the public sector, there's about 80–85% of the population covered there. In the private sector, you've got 15 to 20%. It's as much as that 15% potentially in the medical scheme environment. Then you need to add some people that are on those insurance products. And then there's quite a few people who obviously are cash paying, but they do come to private practitioners, GPs, dentists, pharmacists, etc. And we include all of those. They make up about 20–21%. At least that's what we estimate. However, if you look at medical officers in the public sector and general practitioners or primary care practitioners in the private sector, the absolute numbers, it's about 50–50. However, if you divide it to the population covered, that's where the staggering maldistribution is evident. So obviously less specialists in the public sector, majority are in the private sector. If you look at dentists, for every 1 dentist per 10,000 in the public sector, there's about 10 dentists per 10,000 in the private sector, and the figures are very similar for pharmacists. For GPs as well, huge maldistribution. Majority of them are in the private sector, and less so per 10,000 in the public sector. What is therefore critical, successful implementation of NHI cannot take place without the private sector providers being on board because of this maldistribution. And obviously things like certificate of need, while it's important, is not necessarily going to address this thing overnight. So before we go into the details of that 5 or so pages that are in the NHI, a quick comment. That section should only be a couple of lines that inform the NHI fund what they can do and not necessarily the details of how it's going to be done. When you see the content is that, it's clear to me that the officials in Department of Health, the lawyers that are there, don't know the function of legislation and don't know the function of regulations. Most of that content should actually be in regulations and not legislation. Legislation should just say, NHI will pay for services for a defined set of benefits, and perhaps the minister will publish regulations on the details, or the NHI will publish gazette kind of thing with all the details of reimbursements, etc. Not necessarily the way they've done it. In short, the way they've done it, the Afrikaans word really comes to mind. It's a good gemors. Okay. Unfortunately, this is people who are ill-informed about how remuneration, how reimbursement works going into this. By writing in those details, if you choose that that's not the way to go, it might take 5 to 10 years before you change an act. And I don't think when it comes to reimbursement, which depends on a regular basis, you can wait 5 to 10 years before you change it. So let's consider perhaps NHI is implemented and what that impact will have on you. Firstly, in the short term, they're talking about implementing primary health care. Now, they haven't really specified it. They haven't come up with the details of the benefit package, but let's just assume it's the kind of thing that you get at the primary care clinic in the public sector. So what does that mean for family practitioners out there, the family medicine specialists, and I'm not sure if the other service providers who are classified as primary care will be involved or not. It represents great opportunity for primary care practitioners compared to the extent that they marginalize in the medical scheme environment and the benefits that's there in the medical scheme environment. So yes, huge opportunity, no need to run away from the country like many are doing already. I think the important thing is, what do you do between now and getting ready for that environment? So a lot of the discussions are relevant in preparation for that time that comes about, but also they're relevant right now, irrespective of whether there is going to be an NHI or not an NHI. So the critical is to invest in an electronic health record. Now, many of the software companies do have the billing systems, but they also have built-in electronic health record. Please start using that and get used to start capturing information and see if there is potential for that system to be on a tablet or something so you can use it all the time, and depending where you're working from, you don't need to go back to a laptop or desktop, etc., to do this type of activity. What is also important is when you're setting up your practice, or when you have your practice right now, is to look at what are the essential services that are to be delivered and whether you do have those essential equipment. I once did a talk in KZN, and I talked about using peak flow meters, and one of the colleagues came up to me after the talk and he said, you know what, in my practice, my patients can't use the peak flow meter because they don't understand how to use it. Now, he's chosen to be in a rural environment where perhaps there's a language difference between himself and the people he served. And that's the excuse he's given out there why he can't have a peak flow meter. And I think the rest, you know what should happen there. When it comes to level of reimbursement, there's no clarity at this point in time, and I'm sure they'll be engaging with you further or engaging with the representative bodies further. But I think we need to change our mindset as to how providers, particularly primary care level for primary care services, need to be reimbursed. We need to start thinking about population-based reimbursement, not patient-based reimbursement. Patient-based reimbursement depends on who walks through the doors and seeks your help. However, there's a lot of people out there who might be healthy, and there's an obligation to keep them healthy. While they're not visiting you, does not mean they don't have health needs. And I think that is the important distinguishing factor that we need to consider and we need to take into account. I'm trying to push that with the medical schemes at the moment, but it's a slow process. So this whole thing of population-based reimbursement is absolutely critical, and I'll give you examples of it in the next 2 slides, why it's absolutely important for us to consider that. You would see that in that document, the NHI Act, that there's reference made to risk-based capitation for primary care services. In 2010, I had to do a presentation to the then Ministerial Advisory Committee. Having done a lot of research in this area in the early 2000s, I recommended that to them. However, in the last 10, 15 years, the evidence has come out that accountable care institutions perform really well when you combine risk-based capital with fee-for-service. Obviously, the way you sort of create the hybrid would depend and make it successful or not, and will depend on the risk that's carried. So a little bit more research is required. I'm surprised they haven't engaged with the industry. It seems to me that since the original discussions at the Green Paper, there's been very, very little engagement with health service providers across the board. Not just primary care providers, but even specialists, and through the talk, I'll give you a sense. The presentation I did to that Ministerial Advisory Committee that got into a document and published a Green Paper was to use two extremes, primary care level and in-hospital level. What are the ways to reimburse? And obviously, there's an entire spectrum between that needs to be considered. What is going to be important going in the future, looking at population-based reimbursement, is wellness, and emphasis on that. Unfortunately, in my days when I went through medical school, Imtiaz and I were in the same class, we were taught the biomedical stuff, learn how to diagnose, treat, but never focused on the prevention side of each one of those things. And I think even right now, when I look at what goes through medical schools, talking to students in that, there's no emphasis on prevention. You have that 2 weeks, 3 weeks in public health, you hear about prevention, but you hear it out of context of the actual disease and diagnosing patients, etc. So we need to change our system, the way we work, and you'll find that in NHI, and yes, if I can help it in the scheme environment, the emphasis will change towards prevention, significant component. And this is not just primary prevention or secondary prevention, it's the tertiary and quaternary levels. Throughout, even the curative components that we're involved in is a step towards prevention. I think if primary care, people often talk about, is NHI affordable? Well, it depends what benefits you put onto the table. And if you look back at what the United States did with all their resources, they introduced Obamacare, and all the benefits they put on offer was all the preventive care interventions that was evidence A and B. So prostate cancer, that's an evidence C, wasn't included at that point in time. I know in the medical schemes I get asked, why is prostate cancer not included? And I tell them, unfortunately, we're not into affirmative action for men. Okay. So just some quick slides on some data from the medical scheme environment. Unfortunately, this is not South African data, but I can give you a sense of what it looks like for South Africa. The first slide is just giving you a sense of flu vaccine and pneumococcal vaccination in the elderly. As you can see from the slide, in the SADC region, the flu vaccine sits at the region of about 10% coverage. And in the United States, for the same cohort, it's sitting at about 80%. So it gives you a sense of the gap and the focus that we actually have at the moment. If we look at pneumococcal vaccine, it's sitting at about 1%, unfortunately. That means it's going to take us 100 years to try and cover all the elderly that I covered in this population. The South African figures, the South African figures, flu vaccine is sitting at about 15%. The pneumococcal vaccine is sitting at about 2%. In South Africa, many, many, many schemes are offering these as benefits. Unfortunately, it's maybe not well communicated to the members, maybe not well communicated to the providers, and therefore there isn't significant take-up of it. I know there's a lot of anti-vaxxers around as well that might be sending out the story, but this gives you a sense of the prevention stuff that we're not necessarily doing. If we look at the next one, cervical screening and breast cancer screening, unfortunately, in the SADC region, it's sitting at about average of 12%. In South Africa, mammograms is about 20%. Cervical cancer screening is about 30%. Shows that even though it's a prescribed minimum benefit, there's inadequate take-up of it. And that's unfortunately just giving you a sample of what we see related to the outpatient quality and care that's delivered out there, which brings us to an important component of what is needed in our environment, not just in NHI, but right now and what we need to focus on. The important thing that's not being focused on is quality assurance, and quality assurance for literally all stakeholders, not just yourselves, because remember I talked about the kind of equipment you have in your rooms, etc. But it's also important for the regulators such as HPCSA. Many of my engagements with them, if I look at what they're doing on a daily basis and a yearly basis, they don't even have a clue about what quality assurance is about and what they should be doing out there. Their mandate is protect the public by regulating service providers, but half the things that are required for quality assurance, they're not touching on at all. The important one potentially for yourselves is doing medical audits on a regular basis. Unfortunately, HPCSA hasn't picked up on that, so that's a big opportunity to earn CPD points. Hopefully, maybe there's some more lobby that can go through to get people to do that. Example of a medical audit, there's a whole process. I mean, you can get the guidelines, look at the guidelines, and then establish what you're supposed to do on a yearly basis, quarterly basis, something like that. But just giving you an example, almost all disciplines kind of thing come across hypertensive patients. Just think of your cohorts of hypertensives you have and you come across, what percentage of them are actually controlled? The figures are quite staggering there, what percentage are controlled. International figures for high blood pressure, only 10% of patients are controlled. The Haynes study shows also about 10% of people controlled. Some of the demographic health survey, and if you look at expected prevalence of high blood pressure, and drop it down to those that are known in the private sector, potentially only about 15% of patients are controlled. So this is the kind of information that will come out if you do medical audit. And that will obviously then, once you start doing that in your rooms, hopefully it will encourage you to try and find out what the problem is. Is it on the patient side? Is it on your side? Is there education issues, or is there anything that needs to improve on? And this is critically important. I know some medical schemes have introduced some performance-based reimbursement. I'm not sure how that translates into improvement of quality or so, but I have been informed by HQA that some of their measures, process measures, have been increasing over the last few years. So that's probably a good sign. So NHI benefits and the impact on health service provider, the emphasis is on referral pathways. Unlike the ethical rule that was implemented in, I think, the late 80s during Rina Fenter's time, where the guys at the MASA, that was fully focused with specialist guys, they introduced a law at the HPCSA, or ethical rule, that says people can go to any practitioners of their choice. The reason for driving that agenda was because medical schemes insisted on paying for specialist claims only with a referral note. So once they introduced that, I'm not sure why medical schemes changed their practice, because HPCSA ethical rules apply to professionals and not medical schemes. But anyway, it got changed, and that resulted in a system that really is collapsing, and that needs to change. Fortunately, Health Market Inquiry has recognized that, but we're still waiting for some changes to take place. But in this whole referral management process, there's obviously going to be a reduced role for specialists, especially if primary care is going to be implemented. But that doesn't mean there's no role. If you look at the New Zealand health system, there's a mentorship role that specialists play to primary care practitioners. Patients don't just get referred over to specialists. The specialist is a consultant to a group of practitioners. Primary care practitioners will do what they need to do before they send it out. They'll have a chat with the specialist, perhaps do a few more investigations or whatever needs to be done, try a few more interventions. And if that doesn't work, only then after discussion do patients get referred off to specialists. And that kind of mentorship role, or a kind of capitated consulting role, is where we need to be moving towards. And that's how we need to change our system a little bit. But yeah, we've got to wait for the ethical rule of HPCSA. The ethical rule, unfortunately, is not aligned to the NHI Act at this point in time, but that's something we'll engage with them on an ongoing basis to see how we can get them aligned. The specialists in this consulting role, even though they introduce primary care, you can potentially capitate that service for a given population of service providers, and you would definitely then have a sense of the population that they would be serving. And you could potentially give them fixed fee or even a capitated amount type of thing for referrals. Most specialists deals with higher levels of acuity, so there's going to be a significant role for fee-for-service for them going into the future. The big gaps right now that we need to think about fixing, that will help into the future is this whole thing about reports to family practitioners. Family practitioners refer to specialists. Sometimes you never see those patients again. But it's critical. We need to get back to the old days where a patient referred to a specialist. There'll be a report at the end of that consultation or that hospitalization that comes back to the primary care practitioner. That's all about continuity of care at the end of the day. What is currently legislated in the National Health Act, and it's not fully implemented, is this whole thing called discharge summaries. It's in the Act, and maybe to Melomed as a hospital, what's happening in your place, and perhaps you need to seek some legal opinion on how that should be implemented in your environment as well. Let's start implementing those discharge summaries and using that as the potential referral note back to the primary care practitioner. These are important things that specialists can do right now. It's important part of a health system strengthening, doesn't have to wait for NHI to come through. These are important interventions we need at this point in time. I've included hospital reimbursement because the NHI Act makes reference to it, and there's implications for the professionals because it talks about global fees, and I'm not sure if you've seen it. It says that hospitals will be paid, remunerated using DRGs, that's diagnosis-related groups for those that don't know. But diagnosis-related groups is probably good for acute care, the inpatient care, the overnight stays. It's not necessarily sufficiently fragmented enough for day procedures. Maybe it does cover it adequately or cover most of it. There is a thing called day procedure grouper, not considered in this environment. There's also something called the the Johns Hopkins ACG grouper, which is important one to consider if you're looking at hospitalization from a population-based reimbursement. So for a given population that feed into a hospital, there is a potential of developing, using ACGs to reimburse hospitals as well. But as I said, the most important thing is reimbursement for global fees in hospital. What that means is that the hospital or whatever entity that's created there will be reimbursed for the hospital component, the treating practitioner, the anesthetist, the pathologist, the radiologist, the dietitian, physiotherapist, all of them combined as a global fee. That's what global fee means, and that's how it's going to affect yourselves and going to affect the hospitals. Now, I know that NHN, which is your representative body, Melomed, is working on diagnosis-related groups, but I don't think that they're working on global fees at this point in time. So that's something you might want to think about doing in-house. Okay. I know Department of Health, as we sit around the table, they are working on DRGs already, so perhaps you need to start looking at it internally yourselves, how it affects you. Critical component that relates to those referral pathways, etc., that's not there in the current environment is continuity of care and coordination of care. Solo practice, you can't provide 24 hours care, 7 days a week, 365 days a year. So what happens is primary care practitioners, and you know this well, you go to your rooms, end of the day, that's it, you do your service. After that, what happens? If the person is ill, they go to casualty. The casualty person doesn't know the person's history at all. Going to redo all the bloods potentially that were done the day before. Fortunately, now there's information you can get out of the apps and that. But that's the problem, is the continuity of care that will be missing. And I think for the last 14 years, when I've been talking to primary care practitioners, I've been talking about we need to move away from solo practice. We need to start getting together into group practices so you can provide this whole continuity of care and coordination of care. Coordination of care, fortunately, as of November, is a reality. And in fact, since I think June or July this year, from a practice code numbering perspective, is a reality. You can set up multidisciplinary practices, whether it's a nurse, physiotherapist, dietitian, specialist, primary care practitioners in a group, and start providing coordinated care. Coordinated care is much more efficient care and often results in better quality of care for the patients. And I think that's an important way to think about this going into the future in planning for the time when NHI comes in. If you look at that 5 pages or whatever of reimbursement, they haven't thought about multidisciplinary practice and how they will be reimbursed. Potentially it might be global, potentially it might be episode-based, a group type of thing. Chair, how far am I on my time? I think I'm almost clear, done. Okay, the most important part, the contracting. Yeah, this is a worry. So before you start to think about contracting, the content of the contract becomes critical. How much am I going to get paid? What services am I going to be expected to deliver? Is there escape clauses, etc.? I'm not going to go into those details. That I'm sure you'll work with your representative body or your lawyer is going to tell you how to deal with that. I'm going to go through the steps that you're going to have to take, and you decide whether it's a minefield or not. The first step, obviously, is registration with your professional board. We know there are some guys who've come in the country and who claim to be doctors but are not necessarily registered with HPCSA. But from your perspective, are you paid up with HPCSA or the nursing council or whatever other professional councils that are around? There's about 7 of them around. Because if you're not paid up, then you're not a valid provider, and therefore you will not be offered in contract. The next step, obviously, once that is in place, and I assume most of you already have it, is to go to the next phase, which is going to the Office of Health Standard Compliance and get certified. But there's no details of how this is going to take place. On the practice code numbering system, PCNS, there's about 70,000 practices there. Potentially, if you look at the GPs, there's about 16 or 17,000 primary care GP practice numbers. Office of Standards Compliance have limited human resources. I don't know how they're going to complete that in whatever period of time that they're going to have the NHI implemented. So it's potentially going to be phased implementation, not just nationally. It'll probably be regionally, target groups, vulnerable groups, etc. So it'll be a limited and slow uptake of it to the extent they can manage. So that's going to be a rate determining factor. But if you think that's enough, not enough. There's nothing in the NHI Act that says you have to register with Treasury. So any service provider to the state has to register with Treasury as a service provider. And there'll be a whole lot of requirements. Most important, are you up to date with SARS? Because if you want money from the state, you need to make sure you've paid them up. For those that have tried to provide vaccines and were rejected, maybe it was your SARS status that wasn't up to date, and that's why you got told no thanks. Okay? So if you think that's all, then it comes to the very next stage. Now you will have to get accreditation by NHI fund. The meaning of accreditation is got to do with quality. Yes, you get certification from your universities and your colleges, etc., and you can register with the HPCSA or whatever other regulatory provider. That just says you've passed in exams, you've completed your internship or whatever, and it's good to let you out in the public. It does not assure that you deliver good quality care, consistent quality care all the time. That's what accreditation means, and that's what it's about. Unfortunately, in the context of the way this is worded, it falls under this thing called certification, this Office of Health Compliance Certification. So I'm not sure what the NHI office is going to do with regards to accreditation. The description that was given to me by the Department of Health is very much like the way you apply for the practice code numbers at this point in time. It's that, if that is the accreditation, then unfortunately in my definition book, it's validation. It's not accreditation. Accreditation is about quality and maintaining quality and assuring quality. Okay? So this is one of the, why I say the NHI bill is, and this section in particular is a bit of a chomors because they got the definitions all wrong. They've heard some terminology used here and there, and they've thrown it into here. If you read the Act, there is no way in that Act you will find under the definitions accreditation and what it means. Okay? Obviously, they will communicate a lot more to you when they want to, your signature kind of thing. So please remember that even this component here, they'll be looking at your CIPC, especially if you're incorporated, and if you're a for-profit entity like hospitals. Those are all the kind of things they'll be looking at. They'll be looking at fit and proper of the board of directors and trustees or whatever else, whichever way you set up your company. Okay? They will even look at if you've got a criminal record and make a decision whether you should or shouldn't get a contract. Well, at least if I'm working at the NHI, I'll be doing all of these things. So at the end of the day, this accreditation is validation, and the purpose of it also, to some extent, would have been covered under certificate of need, some of the information, but obviously that's gone out at the moment and it's in court at this point in time being appealed. Only once all this is complete will the contract be put onto the table ready for you to sign. Okay? I'm not sure if you're happy to go through all the above. What they haven't made clear is who's going to pay for this process and what's it going to cost. Do you have to pay a fee to Office of Health Standard Compliance? Do you have to pay a fee to be registered on Treasury website? Do you have to pay a fee to the NHI fund to be able to apply for a practice number type of thing from the NHI fund? No details available. Or is that cost that's going to be incurred here going to be included in your reimbursement component? We don't have clarity on that, and hopefully that's going to be part of the questions you can ask them when they come to engage you further. There's this whole thing about user registration. It says only accredited service providers will register patients on the NHI fund. So if you use the analogy right now, as health service provider, we want you to register members for the medical schemes. That's an impossible task kind of thing, will never happen. And it shows clear lack of understanding of governance. NHI fund should register its own members. It shows that they assume they own public sector facilities, and the public sector facilities will therefore register the members on the NHI fund. NHI is about separating the financing side from service provision, very much like medical aids and yourselves at this point in time. You keep them separate and you try to keep these guys accountable to each other. That's what NHI is supposed to do, separate financing from service delivery. But in the way this is written up, it's clearly there's not much of separation that's going to take place. Okay, so registration of users, I think I touched on it already. The important component to you is who's going to pay for all this resources. If you're an accredited provider and you decide you're happy to register, you might need system changes. You might need to have a new person at the front of your rooms kind of thing to register patients for you. Who's going to carry that extra cost? They've never discussed this with anybody, but that's what they put into they assumed what they're going to do in the public sector is for them. So they haven't even discussed it with province, that province might need to hire people at the front desk to register NHI patient. As it is, we know that provinces don't have enough posts, don't have enough money for posts, and I'm not sure who's going to pay for this extra resources to register patients for the NHI. And these are obviously two separate legal entities. The province is different from the NHI funds. So very quickly, I'm almost done. Some of the additional components and the last things. You need to think about the WHO family of coding that's going to be considered. They have decided that they will be going the ICD-11 route, and I mean, from WHO perspective, that is what's going to be implemented around the world. It's already implemented in some countries. The procedure coding won't be the RPL as you're familiar with. It's going to be this ICHI, and that's not sort of a scratchy skin. It's, what's it called again? International Classification of Health Interventions. That's the coding structure that has been decided on. FISC, which is Private Health Information Services Group, whatever, are already starting to work on ICHI, looking at the gaps. It's a good idea for you to engage with your service providers, representative bodies, to find out what are they doing with ICHI, what gaps are there, how can they contribute, or how can you contribute towards filling those gaps so that at least when it comes implementation time, everything is in place the way you need it. Okay. Critical, the whole issue of quality of care. How are you going to assess that? How are you going to assure that going into the future? As it is currently in the public sector environment, there's lots of litigation going on. And if you want to mitigate that litigation, you want to make sure that resource available for service delivery, you need to focus a lot more on this quality of care. And if you read the NHI green paper, white paper, the second white paper, the first bill and the second bill, and now the Act, there's emphasis on performance-based reimbursement. The whole world is moving in the direction of value-based care and value-based reimbursement. So that will come, and the only way to assess value, there's three components: patient-reported outcomes, the quality of care delivery, and what is achieved on efficiency in terms of cost of care. So those are the three pyramids, important things that will be looked at on an ongoing basis as to whether we're achieving some kind of quality and efficiency. This is obviously from a Health Professions Council perspective. How are they going to try to proactively look at quality and the litigation? For those of you that are doing RWOPs, working in public facilities and getting some private sector done, there's a whole lot of implications there for you. I don't even know if you will get a contract or not from NHI, but that's a whole debate kind of thing, and probably lawyers will have to look at it. Another 10-15 minutes talk is about the practice for professionals, and practices are also employers. So there's implications for you as an employee to some extent. That's another day, another half an hour talk type of thing, and we'll leave that out for now. Okay. The last and most important thing is trust is built through collaboration. Unfortunately, on the NHI, the last 15 years, there's virtually no collaboration going on. There was Treasury with Dr. Professor Musa or something on capitation of some sort. I don't know the details of what happened there, but there has been some engagement, but I'm not sure whether the profession was taken seriously, whether your submissions and the past have been taken seriously. Quite simply for me, the input I've made in 2010, looking at primary care specialists, it looks like there's never been engagement in the 15 years. The areas in between hasn't adequately been covered. A lot of research that's been done in health systems over the last 10, 15 years haven't been taken into account in formulating this. It seems like people who don't work in the reimbursement environment wrote that chapter. And that's why I say it's unfortunately a remorse, but now that it's an act, let's wait and see what happens from the court processes. And hopefully when they say we open to hear your complaints, this is one of the areas that you get your representative bodies to talk about. Thank you.
Dr. Patel, thank you very, very much. Appreciate you shedding light on, how did you describe it? The gemors of the NHI. Yeah, collaboration would be great. I mean, Afrikaans has got such a lovely way of expressing so many things. Many years ago, 1967, 3rd of December, there was a lovely Afrikaans phrase that came out of the hospital at the time. Christian Barnard, or Dr. Christian Barnard, was doing the world's first heart transplant. There were no photographers there because I'm not sure he knew it was going to work. And the reason I know that, or we know that, is because the last remaining eyewitness to the heart transplant shared the story just the other day. And she described that moment when the transplant happened. She said the theater was dead quiet. Her name was Dee. She was a lung perfusionist at the time. No one said a word, tension in the air. Just silence. Christian Barnard was leaning over Louis Washansky, and all of a sudden he looked up and he looked around and he said these famous Afrikaans words, "O God, dit gaan werk." It's a true story. So we can only hope and pray that with collaboration, with private and public putting their heads together, getting into a room and bashing this out, getting UHC to work alongside NHI, maybe one day they'll come out of that room and look around and say to the rest of us, "O God, dit gaan werk," because we need universal health coverage. Our next speaker, ladies and gentlemen, needs he needs no introduction. We know that. He's described as a former medical doctor. I don't think you get former medical doctor, but medical doctor, who in 1994 closed his flourishing practice to follow a calling from his spiritual leader to serve humanity across all boundaries, racial, religious, and geographical. Since founding Gift of the Givers in 1992, one of the most respected humanitarian organizations in the world, Dr. Imtiaz Sooliman has led the organization through remarkable achievements, delivering over 6 billion rand in aid across 47 countries within 21 different categories of humanitarian projects. Dr. Sooliman's work has transformed hundreds of thousands of lives, from designing the world's first containerized mobile hospital to drilling 550 boreholes during our devastating droughts, to the delivery of 3,500 oxygen machines during COVID, to rescuing a survivor trapped for 8 days in the rubble of the Haiti Haiti earthquake. He's also received no less than 10 honorary doctorates for his humanitarian impact, which means he's not just Dr. Sooliman or Dr. Sooliman, he's Dr. You get the idea. You know, when who you going to call is a line associated with Ghostbusters, but when disaster strikes, who you going to call is associated with one of our favorite South Africans ever, Dr. Imtiaz Sooliman. What a pleasure to have you with us tonight, Doc. Looking forward to you sharing your insights and just, talking to us a bit about the humanitarian challenges and ethical responsibilities in healthcare. Why don't you give Dr. Imtiaz Sooliman a huge round of applause.
Thanks, Michael. Thanks, Mr. Borat family, Ibrahim, Shamima, and Melomed. Thank you very much for the invite, and thanks for all the support you guys have been giving us. Support from the private sector, working with government and public hospitals is how we're going to build this country together. You see, you spend a lot of time on regulations, type of rules to follow, what forms to fill in, but in the process, do we understand why we became doctors? Ask yourself, why did you become a doctor? To serve the people? To enrich yourself? To charge 5 times medical aid rates? To ask people to put your money down before we see you so we can get your money before you die? I'm being blunt and obvious. We need to question our ethics, our morality, and our compassion. We've moved away from that. Whilst we're dealing and fighting with government and with medical aids and everybody else, we need to introspect. Medical care efficiency is not machine-related. We worry about robotics, technology, all advances, AI, but the most important critical element is missing is human compassion. We've lost that. In my time, the first page in the book was reassurance. Do any of us do that? We send the patient for a whole lot of tests. Tests come back and you say he's fine. He gets one word, is fine. He spent 15 grand on tests. He doesn't even know what was done on him. But the message is fine. We've lost communication skills. We've lost taking the time. We've lost the reassurance. We've lost the humanity. We got teams. I'm going to give you some examples. We need to understand what patients go through, what hardships and difficulties they go through. And we need to understand if we were in that situation, what we would do if we were in that situation. So I'm going to give you a couple of practical examples. And the credit goes to my teams who go beyond the call of duty and show their true humanity, the medical guys and non-medical guys. I'm going to give you some international examples. I'm going to give you some local examples. So let's take a local example first. 2 years ago, Ali, sitting on the table here, was in Tozrafir. It was a non-medical project. It was January 2022, and we needed to deliver stationery to the school. Tozrafir got a 95% unemployment. There's no banks. There's no ATM. Most of the shops are closed, and people don't have proper services. But we only knew that afterwards. So he goes to the school, gives the principal the stationery. My guys are trained to pick up a problem. They don't go deliver stuff only. They can pick up a problem in any town or any community they go to. They train for that. So he sees a child crying in the hall, and he asks the principal, why is the child crying? So the principal said the child got a toothache. So what's the big deal? Just pull the tooth out. The principal said it's not that easy. There are no dentists here. So what does the child do? The principal says suffers. 2 months, 3 months, 4 months. I don't know if you guys remember when you're small, how painful toothache can be. He said, how many children like this? He said, they're all over. There's many like these kids all over, suffering with toothache. A simple thing like a toothache, there is no solution for. So we said, what about a clinic? Yes, there's a clinic. Nurse comes sometimes, doesn't come sometimes. They come, there's no medication. Sometimes the doctor comes, sometimes the doctor doesn't come. That's the ethical public responsibility. The doctor is paid to come, and quite often we shirk in the public responsibility. Then the government looks bad. We have consultants who moonlight, who are supposed to be in the wards, but they're in their private practices. When they get called by the registrars or the junior doctors, they say, don't disturb me. That's stealing. You're getting paid to do a service to help people who got nowhere else to go, who put their life, their trust, and their faith in you, and you've betrayed their trust by walking away to look after a double income. We have not fulfilled your responsibility. So they said, no, doctor. So Ali called me, and I called Naeem. Naeem is my medical coordinator in the Western Cape. I said, we're going in full-scale intervention inside Toes Rafir. Naeem is a dentist. He got 10 dentists. We got GPs, neurologists, cardiologists, orthopedic surgeons, general surgeons, physicians, dietitians, physiotherapists, occupational therapists, the works. We said, we're going to check out the entire town and all the farms around the area. We get there, the school arranges everything meticulously. You see, people may be poor in resources, but they're not necessarily poor in caring, in organizing things, putting things in a great system in just an ordinary school. If you go to Toes Rafir, you won't find a single paper on the road. They're proud of their town with 95% unemployment. They pick up all the papers and they recycle it. And they try to do the best they can. So we put the kids the dentist chairs on. What we did is unethical in that circumstances. Normally when you go to a dentist, you try to keep the child right inside. The kids outside can't hear the sound, the child is crying, and you have all the doors closed. We couldn't do that here. It wasn't possible. 10 chairs in a row, 10 kids on the chairs, and the other kids are sitting immediately opposite. They're watching the 10 kids. And the teeth are being pulled out, and the kids are screaming on the chair, and turning and tossing and doing all kinds of acrobatics. We expect the kids from the side to get up and run away. They don't do that. They wait their turn. It's easier to watch your friend suffer, but have the tooth out, because it's far more worse suffering for 3 to 5 months with 3 to 4 rotten teeth. They console themselves by saying, I'm going to laugh at my friend. And my friend finishes and comes to side, my friend's going to laugh at me. So they console themselves. Some kids, 7, 8 years old, walked in all alone. Kids are scared of dentists. Well, today it's different. Today's kids are a bit more advanced. But in the old days, we were all scared of dentists. Even the dentist is scared of the dentist. And in any case, the kids go, and the 8-year-old kid walks in alone and sits on the chair, and they leave with such satisfaction, such contentment. Here's the tooth monster. They pulled out, I think, close to 1,200 teeth. Unfortunately, there's no teeth recycling. We would have been in big business. But 400 kids went home very happy. It's a simple thing. It's a tooth. We gave them free service. I've never been stumped in disaster ever in my life, but I got stumped on that day. The first 300 people came for eyes. They couldn't see. They couldn't see, not because they have some degenerative disease, but they just had a refractive error. They needed to have a lens and a glass. They didn't have that. So the teacher tells the child, you're stupid. The child can't see the board. The impact of that is you destroy the self-esteem of the child. You destroy the ability to be positive and to think and to work. Old people can't see the books. They can't see their prescription. They don't know what medicine. They take the wrong dose when they get the medicine. They become totally unproductive as children and as adults. It was heartbreaking to tell them, sorry, we don't know how to help you. Because to me, to fix eyes, you have to go to an optician and get this big machine and look into the machine. How are you going to bring that here? I don't know the technology. That's the first time I got stuck. So we didn't take ophthalmologists for cataracts too. In any case, the physiotherapists, everybody else did their job. People broke down because the compassion in the care that was given. A great credit goes to our young students. You see, I don't take students in my medical teams. But this time, I decided to take students because they learn medicine through correspondence during COVID. You can't learn medicine through correspondence. You have to be on site. So we took the students from UWC, we took the students from CPUT, training opticians, paramedics, to dental care, and other whole lot of medical students came to help. They learned two things. They learned professional medicine from those who were more skilled above them, my professional teams, and they learned humanity. They learned respect. They understood the hardship of the people. They had no difficulty sitting and writing a history and taking one patient from the one consultant to the other consultant to the pharmacy to getting the medicines to putting them in a wheelchair to helping on the way out. They learned courtesy and how to respect people. We've lost that in the medical profession, sorry. We've become money-oriented, see as many patients as possible, and get done with the job fast. We've lost the time to take and listen to people. But we still had an unsolved problem. What do we do about eyes? Life carried on. 2023, my daughter couldn't see. So I go to an optician. In 48 hours, she can see again. And God put a thought in my head, hey, you didn't do your job properly. Sorry, that was in 21, and that was in 22. The first was in 21, and then it was 22. You haven't done your job properly. And I'm thinking, how do I still solve this problem? I landed up in the Vineyard Hotel for some business in August 2022. AMS, Farad from AMS brings somebody, introduces the guy to me. What's your name? Reggie Naidu. What do you do? I'm from the African Eye Institute. Spirituality is key in Gift of the Givers. We don't function like other NGOs. Gift of the Givers is not my organization. I didn't get up one morning and say to myself, okay, I think today I'll form an organization. I couldn't. I had 3 private practices. I was running Monday to Sunday, 7 days a week, after hours, weekends, calls. No time to set up another organization. It wasn't my organization. It was instructed to me. If there's time, I'm going to that. So it was very spiritually based. I'm from the African Eye Institute. What do you do? Oh, we provide lenses and we provide frames. How do you test the people? We take the big machine in a van or something? No, we do it from a cell phone. You test the people's eyes from a cell phone? When did this happen? New technology. I said, we need to go to Tosafir. He said, when? I said, Monday. So we make the arrangements, and the following week we take 60 people this time. The dentist monsters were there, and they pulled out another 500 teeth from another 500 kids and adults. But the joy and satisfaction was in the eyes. Those people came smiling. Oh, when I spoke to Reggie, he says, look, you've got to speak to Professor Kovan Naidu. He's from the Esselout Foundation, the biggest eye guys in the world. So I call him, and it says, only one problem. You can only see school kids. So I said, Professor Naidu, what am I going to tell the old people? Did you come a second time and I'm sending you back again? That's not possible. What are rules for? But to be broken. And I said, break the rule. He said, of course, you're right. Rules are to be broken. See the old people also, no problem. That's compassion. That's the language of the heart. That is understanding. That's what human beings are all about. And the smile and the happiness of those people when they tested their eyes. We then made the frames, made the lenses, and Ashfaq from, what's his name? No, Zal Conquer, yeah. He ran some eye company here. He went and put the glasses on. But whilst we were doing that, we found 69 people with cataracts. We took the ophthalmologist this time, we got clever. And we said, yes, you got cataract, so what? There's no cataract facility in Tosafir. What are you going to do? There's no point in making a diagnosis and do nothing about it. It's a pointless exercise. Rather, just don't do the diagnosis. You're wasting time. But we had started something earlier. From COVID, we got very involved in health in this country. We used to do health in a small way. There's always a problem to do something, the public health service. You need to find an MOU, you need to sign an agreement, you need this permission, somebody has got to sign the form, and somebody else above him got to sign the form. During COVID, I signed no forms. I just walked into 210 hospitals in the country, and I broke every rule there was in the public service. And I said, you got a problem? Get somebody else to help you. And nobody said anything because everybody was scared. So we walked into every hospital, we put in PPE, scrubs, we put in pulse oximeters, thermometers, we gave them hygiene packs and a whole lot of linen. We set up dedicated COVID facilities with oxygen, high care facilities, infrastructure we built. We put in boreholes in hospitals. We provided paramedics. We supported the doctors, gave them encouragement. We called them hospital heroes and gave them just gifts to keep them motivated because people were very depressed and very scared. And I'll come to one more thing this time about oxygen machines. So we did that in every hospital. And then the biggest problem with COVID was catch-up surgery. Everybody cut out the elective surgery. Everything collapsed. So people had a long backlog. From 3 years now it's 5 years and 8 years, whether you need a knee replacement, whether you need a hip replacement, but the common one is the cataracts. Cataracts fell backwards in a big way. And I'll give you one or two examples about this cataract thing. You see, there are still very committed people in the public service. Dr. David Stephen, ophthalmologist at Eastern Hospital. We didn't go to him. He came to us. He said, people are suffering. They can't see. They're unproductive. They need help. They need cataract removal. Me and my team, meaning him and his team, will come on a Saturday morning. Can you help us with some kind of finances? Give us the lenses, give us the machines, do this, that, and the other. Corporate South Africa is starting to buy into the system. We'll give you free, we'll give you assistance, we'll come and help. It's the systems are changing. Private hospitals, fortunately, are starting to get into the system also. First time, something for free, not for money. Things you guys are changing, congratulations. Things are changing. And so we wiped out the entire backlog of cataracts in Eastern Hospital. We wiped out the entire backlog of Victoria Hospital. And then we went, the 69 patients from Tulsafir, Dr. Juanita, what's her name? Juanita van der Merwe. Juanita van der Merwe, a private ophthalmologist in one private hospital somewhere, screened the patients at no cost. And those, we sent the bus, we fetched them, we gave them breakfast, lunch, and supper. We took the bus, we sent them back, breakfast, lunch, and supper. Those people could now see. One of the hospitals, a private hospital, did free cataracts. The lady opens up her bandage. She looks at the husband. She said, ooh, you gone old. The husband also had cataracts. So he opens his bandage. Hey, you gone old too. 8 years. 8 years of losing love life. No productivity. You can't see your children. You can't progress. You can't see your grandchildren. You lost the love of your life for 8 years. How long does the procedure take? 8 minutes. They lost 8 years for 8 minutes. It's time to stop arguing about how NHI is going to be and how things are going to be. Start concentrating on the patients, because that's why you went into the medical field in the first place. You want to make money? Be an accountant, be an engineer, be a lawyer, litigate people. But you want to do service in the health service, it's not money related. You're dealing with life and death. You're dealing with human compassion. You're dealing with hardship and difficulty. You need to change the way you think. During COVID itself, I told you the other things we did. I was in Tygerberg Hospital, November 2020. It was a time of the happy hypoxic. They just dropped dead in front of you. They smiled, and the next morning they're dead, they're gone. In the car park, in the casualty, in the outpatient, in the house, in the taxi, in the bus. Sitting in the bed, they just dropped dead. We had a serious shortage of, I'm calling generic oxygen machines. Ventilators didn't work. Only 6% of people survive on ventilators. It's a useless machine at that time. So we needed an oxygen machine. To the credit of government, in May 2020, Minister of Trade and Industry, Ibrahim Patel, asked the guys to build a SK telescope. You guys are engineers. Can't we make a machine that can deliver oxygen? So people started putting proposals together, and they came up with a final idea, the CPAP machine. They said, this machine looks very good. Low cost, 12,500 in a machine. A government minister instructed the formation and the production of an oxygen machine. Engineers and scientists, most of them from government, got together and designed the machine. CSIR, a government entity, manufactured the machine. SAPRA, a government entity, approved the machine for use specifically for COVID in South Africa only. Solidarity Fund set up by the government paid 250 million rand, which is a good price. 20,000 machines at 12,500 each. They produced the machines. As South Africans, we got together, we can solve the oxygen problem. The machine has other advantages. A ventilator can only be connected in the ICU. A high-flow nasal oxygen machine can only be connected in the ICU. A high-flow nasal oxygen machine takes 80 liters to 120 liters per minute. So all these big oxygen tanks we have in the hospital, boom, they're depleted. And oxygen companies can't keep up with that. The CPAP machine could be put in an oxygen point above the bed of the patient. It only takes between 10 and 30 liters oxygen per minute and does the same kind of job. So we started putting oxygen points everywhere, but not before there were some problems. The guys involved in the machines tell me, here's the machine, but we got a problem. So I said, what's the problem? He said, we can't get it to the hospitals. I said, you're in a happy hypocrite phase. You can't get to the hospital. What's the problem? Do you have a transport problem? You guys can spend 250 million rand, but you don't have transport to take the damn thing to the hospital. He said, that's not the problem. So I said, and what's the problem? He said, somebody in the health department is deliberately obstructing the delivery of oxygen machines to hospitals because there's no backhand. You're not buying expected machines, so you're not going to get anything under the table because this thing is free. Public hospital guys don't want free things. So I said, give me the machine. Me, I don't follow rules. So I was in Tigerberg Hospital, Nishat Schroeder, and some of the other guys were there in the medicine department. I gave them the machine, a few machines. A few hours later, they called me and said, where you got this from? I said, this thing machine works very well. We just saved a couple of lives. Go to Khairicha, Saad Lari was there, and some of the other doctors were there. I gave it to them. I said, try it. They called me back a few hours later. They said, this machine works. Where did you get it from? Same story, we save lives. I said, our government made it. We had the checklist groups of all the provinces, and all the CEOs of the hospitals were on our chat groups for the 9 different provinces. We started off with Eastern Cape, because they had a major problem with the happy hypoxic phase. Put on the chat, anybody wants oxygen machine? 40 CEOs put up their hands. Yes, we need it urgently. Remember, there's no permission to take it from the government. We took our trucks. In 48 hours, we delivered 900 CPAP machines to the rural areas and other main hospitals in the Eastern Cape. Monday morning, the hospital CEO manager from Kala Hospital calls and is laughing on the phone. And we asked him, who laughs on the phone in COVID? He says, I've been crying every Monday since COVID started, because every Monday is Morbid Monday. We count all the dead people in our wards, which we couldn't save. But for the first time in our history, we had an oxygen machine, and we saved the life of every person in the ward this weekend. Nobody died. How complicated was that intervention? It was a simple intervention that made a huge difference to the lives of those people, their families, their children, and those around them. The Mauritian government called me. They said, we know about this machine. I can put a lot of pressure on government. It didn't take long. I got a form signed. I got them to release the machines to Mauritius. They sent a plane to fetch the machines. It was approved by SAPRA for local use only. And we got those machines to Mauritius for people in another country to use. This country does a lot of good. It's dependent on the quality of people, the compassion. I'm just going to give you 1 or 2 more international stories because there's another speaker after me. We went to a place called Niger. There was famine in Niger. We only had about 7 or 8 medical guys. It was our second medical mission. We never had medical missions before, from 92 right up till 2004. 2004 was the first one, in a place called Hafoun, northeast Somalia. Niger was the second one. And in Niger, when we went, there was drought that killed all the crops, and the locusts ate the balance. So we made an announcement, please come. Hundreds of patients turned up. We said, there's no way we're going to manage this crowd. But there was something very unusual about the pattern of the patients that came. No adult male came. No teenager came. No big kid came. The mothers that came didn't ask for help. They only asked for help for the baby. I'm thinking, why? They got no health care. They got a problem. Why are they not asking? Then after a while, we said, this is not going to work. There's just too many. So I started walking to the crowds. I pointed to the baby. I said, your baby is fine. You can leave. They speak Swahili and French. We don't speak the language. They gave me a big smile and they walked out. They understood the language of the heart. I couldn't understand what's happening here. So I did the second time and the 5th time. My team started doing it. And eventually, they started doing it themselves. They said, go. I couldn't understand this concept. Why are they doing this? That evening, I have a system. Every night on a mission, whoever travels with me, whether it's the government guys, whether it's from the president's office, whether it's from DERCO, whether it's journalists, my teams, we all sit together, and everybody has to give an evaluation. Sooliman gets up first. He was for SABC Radio. He says, Dr. Sooliman, I like to talk first. He said, I walked to the villages of Tilaberi, and 3 to 5 children a day were dying in this village from hunger and the effects of starvation. I said, stop. You answered my question. He said, what do you mean? I said, do you know why no adult male came? Why no teenager came? Why no big kid came? Why the mother didn't ask for treatment? And why the mother walked out of the queue? Because they were prepared to sacrifice their child for us to see the very sick children. They didn't want other children to become statistics inside Niger. There was no guarantee another team was coming after us, but they were prepared to take the chance. Their kid may get worse in 5 to 6 or 7 days, but right now, there's another kid, their neighbor's kid, or down the road, there's more sick than their child, and there's not enough resources and not enough medical teams, so we'll walk out. We talk about faith. Do we really believe in faith? Will you do that with your child and take a chance and walk out? They walked out not knowing if any other medical team was coming. They don't know if somebody's going to save their child, but nevertheless, they walked out. They left it to fate. Whatever happens, happens. Right now, the other child is more important. Do we believe it like that? Test yourself. You pray 5 times a day. You're going to go to Saudi Arabia. You're going to go 3 times a year. Do you really have faith? Ask yourself that honestly. We go to Syria, and this is the last story. We walk into a war zone. I'm about to walk out. I can't find any guy to do a medical intervention. As I'm about to leave, I hear somebody shout, hey, there's Dr. Ahmed. I walk to him and say, you Dr. Ahmed? He says, yes. I say, you speak English here? Nobody else speaks English here. He says, yes, I speak English. What are you? Cardiothoracic surgeon. Where are you coming from? Inside the caves, in the mountain. We're cutting people in the mountain to avoid the bombs. I said, is there a building we can convert into a medical facility? He says, yes, we got the exact building. He takes me to a building. It's supposed to be a center for old people. Nobody stayed inside there. The town was liberated 14 days before I got there, the place called Darkush. I crossed the border illegally, across the river in a drum to get inside Darkush. We get into Darkush. He takes me to this building. I said, Ahmed, this building is too small. We can't convert this into an emergency facility. It's too small. I need a bigger building than this. I need a building across the road, and I need other buildings too, and I need that land too. He said, but you haven't seen one patient yet. I said, I'm gift of the givers. This building is too small. So he says, maybe we can go up. I said, yes, we have to go up, but we need an engineer. Maybe we're going to find one now. Now, because I walked in with my gift shirt, and I was a foreigner, and the town was liberated 14 days before, every foreigner is suspicious. But if you walk with Ahmed Gadur, you should be okay, because he's the hero of the town. So other people walked into the building, and a man speaks in English. He said, sorry, I overheard the conversation. You're looking for an engineer? I said, yes. I said, do you know one? He says, I'm an engineer. This is spirituality. I asked him, can we go up here? He said, yes, 2 floors. I said, oh, where did you study? I said, you didn't see the plan. You didn't see the architectural drawing. You didn't see the degree of concrete. You don't know how it's cured, what kind of steel structure at the ground. How you can tell me 2 floors up? What kind of engineer are you? He said, my friend, calm down. I'm the guy that built this building. That's not the funny story. This guy left Darkush several years ago. He never came back to Darkush. 15 million Syrians displaced internally and externally. The day I need an engineer, not any engineer, an engineer that built this building. In that hour, in that minute whilst I was there, he walked into the building. That's the power of spirituality. We went up 2 floors. I took the land across the road. I took the building next to it, and I took 5 more buildings that I stole from Assad, the president of Syria. Took 5 other buildings. We put out rehabilitation. We got dialysis. we got cardiothoracic, angiograms to do that kind of intervention. We do ultrasounds, we put in MRI, we see 15 to 20,000 patients a month. Dental care, physiotherapy, outreach teams, primary health care, 400 patients at a time. It's the biggest functioning hospital in North Syria, totally funded by us. A team that understands compassion like nobody can understand. They are so skilled in war medicine that any country in the world will take their unlimited amount of money to come. They say we're patriots. We're not leaving. What will happen to our people? Who's going to take care of them? The bombs fall while their families are there. We lost some of those people. We lost some of the family members and the hospital staff itself in the bombing. But they stayed. Are we like that? Are we prepared to commit and take care and look after people who are not in our family? Are we only worried about the bottom line? You need to think carefully. Thank you very much.
Sure. Dr. Sooliman, I never tire of listening to you. Thank you for inspiring us. Thank you for sharing your stories and your miracles. It really is very, very special. I've always said Dr. Sooliman for president, but actually that's a stupid idea. Because if you think about a politician, he spends his night, or she, thinking about what he or she is going to say tomorrow. Dr. Sooliman spends his night thinking about what he's going to do tomorrow. So I speak on behalf of the entire audience here tonight. Thank you for doing what you do every single day. Dr. Sooliman, let's give him another warm round of applause. Amazing. And what a great reminder about compassion. You before me, I think it was Patch Adams who said, if you treat a disease, you win some, you lose some. When you treat a person, you always win. And you certainly are doing that, sir. I loved your statement right in the beginning. My men, my team are trained to observe, to just take stationery to a school and end up turning Toja into a blue zone, just about. Observe. I'm not sure how many of you know this, but the most observant detective in the world is Sherlock Holmes. The author of Sherlock Holmes was, in fact, a medical doctor. Arthur Conan Doyle. He was trained in Edinburgh University, and he tells this amazing story of when his character, Sherlock Holmes, was born. He said, I was in a ward round with a professor, Professor Joseph Bell, and a woman walked into this ward round unknown to the professor and just said, good morning. And this professor looked at her and observed. And then he said to her, how was your ferry crossing from Burnt Island? The patient said, it was fine, thank you. And he said, and where's your other child? She said, I left my other child with my sister in Leith. And he said, did you take a shortcut to the hospital through the botanical gardens? She said, I did. And then he said, how's work at the linoleum factory? She said, it's fine, thank you. And then this professor, who didn't know this patient, turned to his students, Arthur Conan Doyle amongst them, and said, you see, when she said good morning, I recognized her Fife accent, and the closest crossing from Fife to Edinburgh is via Burnt Island. And then she has a child with her that's too big for the pram that she's got, so there's got to be another child. And if you look at the soles of her shoes, they have thick clay on them, which you don't find within 100 miles of Edinburgh except in the botanical gardens. And if you look really closely, she's got a dermatitis on her fingers, which is typical of linoleum factory workers. And medical student Arthur Conan Doyle said, Sherlock Holmes was born. Observe, inquire. Our next speaker has been on probably every single inquiry that we know, and that's important in this country. He's contributed to several major national inquiries and committees, including the Health Market Inquiry for the Competition Commission, the Committee of Inquiry into Comprehensive Social Security, and the Ministerial Task Team on Social Health Insurance. Professor Alex van der Heever, a leading authority in health economics and social security in South Africa, currently holds the chair of Social Security Systems Administration and Management Studies at the University of Witwatersrand. He's got a master's degree in economics from UCT. Professor van der Heever has been shaping the field of health economics, public finance and social security since 1989. His distinguished career includes key roles in the Department of Finance, the Gauteng Department of Health, and the Council for Medical Schemes, amongst others. Tonight, he's going to share his insights on the state of the South African health system and, most importantly, the way forward. Please give Professor Alex a big round of applause.
Good evening. So I'm going to give you, I think, a fairly different story to the ones you might be used to on a health system, because my background is at a very strategic level in looking at policy and systems. And the problems that we have in South Africa today, let's say if we look at the example of Gift of the Givers, if you create a system and design it right, you actually enable people from below to innovate and do things without being constricted by the way in which the system is structured. So badly structured systems are extremely harmful because they establish systems of gatekeepers. They establish rules that don't make sense. And to run a system properly requires people who are very capable of understanding the design of big machines that get collaboration between people, and to ensure that it is effective and in the public interest and not in the interests of the people who are delivering services or delivering public functions. This is something that in South Africa we have completely failed to do. And we have to understand where the source of that failure is. Now, we can look at sporadic innovations and attempts to compensate for weak systems, but we also have to take into account that these systems have enormous resources. They have the resources that you cannot just get privately and from private initiatives. They have the resources of the state, billions of rands worth of funding that can do immense good if actually combined coherently in the way in which we design systems. So designing systems, when we talk, let's say, about a primary care system, somebody can talk about, oh, well, we should have people go to see a GP before they get referred to a specialist. Actually, getting a system to provide effective and efficient preventive care is incredibly complex. It's not actually, if you're doing it as a system, it's not just about the individual, it's about the support infrastructure around it, it's about the feedback information, it's about whether or not you can treat at that level and not just refer on. It is also about the incentives that are structured into that entire arrangement. So there's a useful example, the Center for Health Policy, also an organization I used to work for a while ago at WITS, decided to do a study by sending in fake patients to general practitioners in the public and the private system to check on their prescribing of antibiotics. And people were to go in and present themselves with particular conditions and basically deceive the doctor as to what their conditions were. None of the conditions and their symptoms required antibiotics. And the question was, how many would end up with antibiotics? Some of them were instructed, if they were to be prescribed antibiotics, to actually request that they not be prescribed and to see what happened. So the consequence of this study showed that round about 69% of private sector general practitioners prescribed antibiotics when they shouldn't, and 72% of public sector doctors did. Prescribed antibiotics when they shouldn't. That's a systemic failure. So the question is, why is that happening? Now, the problem of just saying we need more doctors, we need people who gatekeep on referrals to specialists is not helpful if there isn't a structural framework in place which has people looking at providing preventive services. Diagnostics is important, treatment is important. So the story from that is that we don't really have a primary care system in South Africa, not in the public sector, not in the private sector. And it's not about funding, it's about the system. If we had to look, I have I was asked by DFID to go and help identify the potential areas for the NHI pilot sites, and I'll get into NHI in due course. Just the areas, because it's a good idea to go and check particular health districts in South Africa and to see whether or not you can make a difference. Now, they're called NHI pilots, which I'll get into, but quite aside from that, there would be an intervention. So part of it was actually to select the worst performing, at roughly 2 per province. And ultimately, it was going to be 10, and we added another one. So we visited a province, we visited Eastern Cape, for instance, and part of the discussion in the Eastern Cape was maternal mortality ratios in that. And the staff of the Eastern Cape Department of Health talk about 50% of the maternal mortality coming from Oliver Tambo region, which was identified as one of the sites that go in. And then you have to ask the simple question, why, when you know that, why, when you can see it in the data, why there is no intervention from anywhere in the country? Now, we have a so-called, a system of collecting some sort of data on districts, monitoring their performance at some level. The data is bad. But if you triangulate it, you can tell what's going on in these areas. You can really see this area is much worse than that area. And it's not because of socioeconomic factors, it's something else. Something's wrong with the way in which medical care is being provided in that area. It's structural. And when you look at organizations, structural failures start at the top. That's where the people establish enabling environments for their organizations to innovate from below, and that they can organize, solve problems, introduce continuously new systems of improvement, targeting the problems that they see in front of them. Now, with this information, the question is, why is there no proper intervention in any of these areas that would systematically change these outcomes? And when you look over time, there is no change. Now, I've examined another set of data, which is to look at the provincial data on financial information, and to even see whether it correlates with maternal mortality ratios. So the financial information is to look at irregular expenditure, unauthorized expenditure, wasteful expenditure, and accruals. And accruals are basically unpaid debts. So you look at these, now the three biggest items are irregular, unauthorized, and accruals. Accruals, unpaid debts, which is a key sign of systemic failure in the management of finances. And now the question was to look at this over time and to compare it to, say, maternal mortality ratios over time, and to see if they correlate. Somebody who manages their finances badly manages their healthcare badly. Well, it does correlate. But when you look at the performance of the provinces, I mean, it is ghastly to see. So the one thing that is important, as with the other interventions where there is information and no intervention, is that you have irregular expenditure which recurs year after year after year after year. So I have a span of, say, 7 years worth of data that I would compare it between provinces to see those that are performing well and those that are performing badly. So Gauteng Department of Health has systematic irregular expenditure that accumulates roughly the same amount per year over a period of 7 years, and no real change, and it accumulates to around about sort of 13 to 14 billion rand in total. This is our state resources. And that irregular expenditure quite simply means somebody didn't comply with procurement rules. When I compare, now their irregular expenditure comes to about 5% of their overall budget. Then I compare it to the Western Cape. Western Cape's irregular expenditure, and it has some, ranges from 0% to 0.1%. And I compare the Northern Cape. Their irregular expenditure is off the charts. And when I combine all those financial amounts and express them as a percentage of non-personnel expenditure, which indicates the degree of financial distress that that province will be under to allocate resources. Provinces like Northern Cape have a figure of approximately 65% of their non-personnel expenditure falls into those financial categories. Gauteng has around about 35 to 40% of their overall budget. Now, irregular expenditure is simple to cure. You cannot explain why the Western Cape has virtually no, I mean they have, but virtually no irregular expenditure, and Gauteng Department of Health has that level. What explanation is there for that? When you look at issues like Babita Deokaran, and why that case is so important. Babita Deokaran, Chief Director of Supply Chain Management, the Gauteng Department of Health. I'd say a particularly dangerous position to be in, because she, unlike many of our politicians, doesn't have 20 VIP protection people around her. But what she's doing is she's looking at the transactions happening within the province. So what she does is she identifies and flags 100 million rands worth of transactions that are fishy and blocks them. And then goes up the chain. Note, she was not a whistleblower. She was reporting within the departmental structure, the hierarchy, to the chief financial officer and saying, I've blocked these. There are these service providers, they are dodgy, we need a forensic investigation. The CFO says, yes, I will speak to the HOD. A little bit later, Babita Deokaran asks again, I'm a bit worried for my safety. Have you spoken to the HOD about the forensic investigation? CFO says yes, and it's going to proceed. Then she gets assassinated. And then we find out what actually happened. The CFO subsequently the HOD denied having received any information from the CFO. The CFO's cell phone mysteriously disappears. The Hawks fail to investigate the laptop and the cell phone of Babita Deokaran for nearly up to a year after her assassination. It sits on a shelf. And finally, they hand it back to the family uninvestigated, which means the chain of evidence has now been broken, effectively. That is why News 24 was able a year later to write a story, because they took that cell phone and that laptop, unlike the Hawks, and analyzed it. Now, what then happened was, although several shooters are arrested in relation to Babita Deokaran, the question is what happened to the forensic investigation? The head of department changed, and the CFO changed the forensic investigation from an investigation into Tembisa Hospital to a general survey-related forensic investigation. The forensic investigators still said Tembisa Hospital should be investigated even after their sample study. No action followed. After the News 24 story, only then was the CFO and the Chief Executive Officer of Tembisa Hospital suspended. 2 years later, that head of the hospital was still under suspension in full pay and died in office. The CFO resigned about 2 weeks ago on the anniversary of Babita's assassination. No disciplinary action had been taken. Now, you look at that scenario, and it is impossible at the Gauteng Department of Health as a system with a budget of around about 65 billion rand a year and approximately 75,000 employees, it is impossible that that organization with that level of resources can be functional. Because at the very top of that system is corruption that is protecting corruption all the way through. On the anniversary of Babita Deokaran's murder, the Gauteng Department of Health indicated that that they were now introducing additional controls to prevent this kind of corruption. And they would be now carefully examining all transactions above 500,000 rand. But here's the problem. All the corruption occurred on transactions below 500,000 rand because the delegations had been given to the hospital to actually approve transactions at that level. So if they were really doing something about this corruption, they would be investigating all the transactions below 500,000, which a person like Babita Deokaran and any half-wit idiot in finance would identify all the corruption in this environment, because it's everything from skinny jeans to hiking boots that are being purchased by this hospital at bizarre prices. So that's an entire health system. But now you look at the Eastern Cape Department of Health. Eastern Cape Department of Health falling apart. During COVID, it is rescued by outside people, but not by the department itself with its own resources. It is a department sitting with roughly 3 to 5 billion rands worth of accruals up front. That means they start the year with a 5 billion rand deficit because of medico-legal claims against them, because they're basically giving cerebral palsy to children. under appalling conditions, they can't manage the maternity wards. They have the worst maternal mortality record, and they have highest levels, very extremely high levels of cerebral palsy. And I'm an economist, not a doctor, but cerebral palsy is something that is mostly not preventable. Most of the cerebral palsy we're seeing in South Africa is preventable. It's being caused by the health departments. So we have billions of rands worth of medico-legal liabilities building up. Gauteng, Eastern Cape, Northern Cape, all the ones with these performances. In all of these cases, they fight them at a legal level. Does anybody go back and change how maternity wards are functioning? No. So this is the problem that we have, is that it is absolutely crucial that we get our system functioning again. And I say again, get it functioning better than it ever was, when it was better, and it has to be much better than it is now for the resources going in. We are underperforming relative to peer countries. We're off the charts. So this is the problem that we have in our public system. In the private system, the health market inquiry is also about looking at systems. Part of the problem that we have is that you have to look at it in some respects at an economic level, because you have to look at the way in which the system is organized and the incentives it's generating within it. And it generates perverse incentives. So you have to restructure aspects of it. That requires that you have structural interventions that change the way in which it's purchased, but government doesn't take control of it, but you change the way the system is responding to coverage requirements and reimbursement systems. So without going into the detail, essentially you look at a private system principally as an economic problem in order to become something that benefits society, as opposed to creating predatory arrangements in the private sector. So the health market inquiry looked at that. It goes through 5 years of a diagnostic and set of recommendations, which it puts forward in 2019. What does the Department of Health do? Nothing. They can claim there was COVID in 2020. It becomes the perpetual excuse for doing nothing, but actually, we're now in 2024. You have a set of detailed recommendations, a detailed diagnostic, you've got statistical information, you know where the problems are, you know where the structural interventions have to be. Not one issue is examined. And it's quite clear when you look at this, is that the National Department of Health currently lacks the capability to evaluate reports like this. It lacks the capability to examine what's going on in the provinces and come up with coherent solutions. So I'll move on to NHI. We had a discussion on NHI. I've gone through that bill, that act, in detail. Just to point out, I have put legislation through government. I have established public organizations post-1994. I understand the kind of difficulties you have in making coherent policy and how to get that through in an environment, and also how to try and get it correct. When I look at that legislation, it is absolutely clear that nobody has done a diagnostic. Nobody really knows what they're going to implement. So one or two features of this bill, the Act, is that the fundamental assumption that has been put in place, it's a rather odd one, is that they are somehow going to raise additional money for government because the resources are too scarce in government, not being wasted or squandered, it's there too little, is by essentially prohibiting coverage in the private sector in order to get that money to shift over into the public system to induce an equitable result. Now, part of my background is in public finance. I teach it. As an economist, I understand how government finances work. I originally worked in what is today the National Treasury, and I understand very much the macroeconomic requirements and prerequisites for the way in which taxes are raised and run and operated in any country, let alone South Africa. So here's the first constraint that you have in looking at grandiose schemes, is you have two ways in which you can get additional government revenue. One way is through tax increases. That means the tax rates change. The other way is economic growth with the tax rates staying constant. When a country reaches what's called tax capacity, That's a point at which tax rates can't be increased any further without compromising your revenue. In other words, you increase that tax rate, you get less tax revenue. The reason that happens is because you encourage avoidance at very high tax rates. You encourage evasion, and you also discourage economic investment and output. So your economy goes into decline because the tax rates are too high. So the point is that once you've reached tax capacity, you can increase tax rates, but you'll not get a cent more. You can double them, triple them. The revenue won't increase by 1 cent, it will go down, because there's now a huge incentive not to pay the tax. So this is understood as a Laffer curve in the way in which it's described in public finance. It goes in a U shape. This is, first of all, an identity, because there are 2 points at which tax revenue is zero. That's at 100% and at 0%. Tax rates are 0%, you get zero revenue. Tax rates at 100%, you get zero revenue. Everything in between, there are 2 tax levels of revenue. For every revenue point, you have 2 tax rates. One that's very high, one that's lower. So we're currently at tax capacity in South Africa. It's the official position of National Treasury. It is also confirmed in statistical analyses outside of National Treasury. That means we can't increase tax rates anymore and expect more revenue from it. Our only way of getting additional revenue is through economic growth, which is stagnated because of the failure of public institutions over the past 15 years. That has severely compromised everything we're doing in South Africa. So government revenue is down because growth is down, not because the tax rates aren't high enough. So the problem going forward is that what do you do with the revenue you get from economic growth? Now, it's not going to, now the idea in the NHI is you're going to increase tax rates to substitute for medical scheme contributions. But you can't do that. You can only get additional revenue from economic growth. Now, what's the best way of deploying revenue from economic growth? You apply it to the people most in need. You don't try and cover medical scheme members. You actually try and keep them out and focus on the people in greatest need. We will never, for the next 80, 90 years in South Africa, be able to raise money from tax increases. We will only ever get it from economic growth. And by the way, if we get 3.5% per annum for 2 to 3 decades, we do very well in South Africa. We are nowhere close to that. Our economic growth rate over the last 15 years has averaged about 0.8%. That's the kind of growth rate the apartheid government was achieving post-1985. Post-1985, we had capital account sanctions introduced after the Rubicon speech. Capital account sanctions meant people were not prepared to invest financially in South Africa. They withdrew their finances, so there was nothing coming on the capital account of our balance of payments. So we had to survive on positive trade balances, which means South Africa, in order to do that, had to prevent imports, the value of imports exceeding the value of exports. The only way they could do that was keep South Africa in a semi-permanent recession from 1985 until 1993, when capital account sanctions were effectively lifted. So our average growth rate during the period was about 0.8, 0.9%, and that was calculated at that time as the maximum growth rate we could achieve without destabilizing the economy. We're now sitting there. So we have to change the growth rate in order to get additional government revenue, and that additional government revenue has to go to where the needs are greatest. The assumptions, the fundamental assumptions in the NHI framework are impossible to achieve. And this is seriously problematic. When you look at the types of growth rate we need to get to reasonable benefit levels that sort of approximate the ideas that are in the NHI report, we would probably take about 70 years before we get to levels where you can talk about almost equivalence between public spend and private spend on a per capita basis. We could get there. If we grow at 3.5% per annum, we can get there in 50 years. If we grow at 2.5%, we will get there in 70 years. Those are our practical realities. Now, what you don't do in policy is build policies on fabrications. And this, to me, is what incenses me in the NHI process that we've gone through, is that the proposals are so unrealistic, so unachievable, so divorced from reality, and so divorced from the priorities we're facing in South Africa in both the public and the private systems, that it suggests rot right to the top. Because while we're doing this, not one person in the National Department of Health or from the minister talks about Kadani, talks about Babita Deokaran, talks about the 500,000 rand that is being investigated for kickbacks for the head of department in the National Department of Law, that the Hawks is investigating, as published in the News 24. That people in the National Department of Health in digital vials manipulate a tender as accounting officers, and they are not even charged in terms of the Public Finance Management Act. That people make payments on that subsequent to the one accounting officer, and they are still not held to account. That disciplinary procedures result in a slap of the hand. Now that's the type of stuff that kills your system. So the issue is that I can go into the detail of what's in this act, but the reality is virtually none of it can materialize, none of it. There is no ability that government has to introduce sophisticated so-called strategic contracting arrangements. Capitation, DRGs, government can't even code at this point. There's no way. The ICT frameworks in government are out of date. They are different between every single facility, and there's no coherence, no understanding of how to basically upgrade the whole ICT framework in the public system, because it's always done from the top, and therefore it never changes, never gets implemented, and there's so much corruption on every single ICT contract that the wrong ICT arrangements are in place in every single facility. So you can't get anywhere. The reason why our facilities are not maintained is because, first of all, in certain of the provinces, they top slice the money and give it to, in the case of Gauteng, Department of Infrastructural Development or Public Works departments, and you really don't know what happens in those works departments. Half the money, at best, disappears into pockets and doesn't get deployed. So if you have maintenance on public infrastructure that is around about 1% of the total value of that infrastructure, it is going to degrade. You do that for 10, 15 years, and you have got a backlog that essentially means in some of these institutions become unusable. That's the kind of level at which we are maintaining our facilities in the public sector. Maintaining infrastructure is the easiest thing to do. Having a proper budgeting framework and operating within it, and I ran the finances for the Gauteng Department of Health in the period from 1998 to 2000 to try and get them out of their deficit at that stage. Had to rectify a lot of problems. Within a 12-month period, you could make significant improvements in financial performance. And a large part of what was done in that period continued up until 2006, until corrupt people were put in charge of the Gauteng Department of Health. So from 2006, you have this degrading. So it's not that difficult. It takes discipline. It takes reasonable systems. It takes people who are competent. It takes people who can problem solve at the top. So the problem that we have, and just to note on the NHI, is that theoretically it says all of you should register as providers for the NHI. The Act doesn't compel anybody to contract with the NHI. It doesn't compel anybody to register. There's no requirement for anybody to actually participate in the process. It's the way the Act is structured. It doesn't actually compel people to become users of the National Health Insurance System. Nobody needs to even join it. You don't, because it requires an express process. Unlike now with free health services, where there's no procedure to qualify for access to public facilities, it now says to qualify for access to NHI structures, you must register as a user. So it introduces a hurdle to access our system that didn't exist before. Why would you do that? But What are the implications of most of the population never registering as users, so they're not going to provide care to them? The Act envisages that there's going to be a massive function shift, that all of the provincial services are going to be placed on the first tier of government, that basically they're going to fall under the National Department of Health, who's so good at running things. And they will begin with the academic facilities. They want to establish contracting units that are operating at the first tier of government with functions that duplicate functions that exist at the provincial level. It doesn't make sense. And the only way in which those contracting units would ever have any money is if the money that is currently allocated to provinces is kept at the national level of government. This is not going to happen. The government is not capable of this transition. Function shifts in government are extremely complex, and function shifts don't just transfer the function, they transfer the liabilities as well, like those medical legal ones. They now become national liabilities if you were to transfer them. The staff become employees of national government, not of provincial government. These are all things that are just, when you start to go through the detail, it is overwhelmingly onerous as a reform framework, and it is beyond the capacity of the 2 to 3 people who are kind of looking at this. So, firstly, what should one look forward to going forward on NHI? Don't hold your breath. It's not going to affect you. None of this is going to happen. The court cases will challenge many of the deeply flawed provisions of the Act itself. And the first one is essentially asking why the President, what information was sitting with the President when he assented to it. If that succeeds, the bill goes back. It becomes a bill again, goes back to Parliament. It's over. If we proceed into the court cases, then you go into how can you take away people's rights to be covered on a medical scheme? And here I'll just mention one oddity in this Act, which is kind of mystified me because it was such a central, pivotal, idea in the various green and white papers, was this idea that medical schemes would only be able to cover complementary coverage. But the Act has no proper definition of what complementary coverage is. Now, you can't use regulations to interpret the Act. That's something that the Certificate of Need case made very explicit. The Act must be clear. So what is complementary cover? So in insurance environments, in any environment, you have complementary cover could just refer to anything that's not covered specifically by the National Health Insurance Fund. In other words, they pay this service at that hospital, that's that coverage. Somebody could say, well, no, it actually refers to a whole class of treatment. So if we talk about heart transplants, so they just do 7 heart transplants a year. Complementary coverage means medical schemes can't cover heart transplants. They can cover other stuff other than heart transplants, even though they can purchase those services. Now that's the distinction between those 2 types that I've just referred to is quite extreme, and the implications are enormous. On the one hand, theoretically, the Minister of Health, at the stroke of a pen, can eliminate everybody's coverage in medical schemes, because that's what the Act theoretically, just whatever he defines as complementary coverage is now no longer can be covered by a medical scheme. That is very unlikely to pass muster in court. So what does it mean at the end of the day? Potentially complementary coverage is just anything that the NHI doesn't cover, which means nothing really changes. So the Act itself is so vague and ambiguous, and I'm only talking about one area, that it is definitely challengeable, unimplementable, and the central thematic ideas are not there. And I think just to make one final point on the overall arguments for equity in this, the assumption was that incorporating medical scheme members into the public system enhances equity. What I've indicated is that fiscally, an improvement in equity is impossible if you have a fixed ceiling on what you can get as tax revenue and you incorporate new liabilities. All you're doing is you're depleting the benefits available for existing public sector users. There is no other result it is equity depleting, and it reduces coverage. It eliminates coverage of people who had before. It makes no sense. So the question is, what's going to happen going forward? The issues I've raised at the beginning about the public system are not being addressed. That is very deeply problematic. We really need in South Africa governance reform of the public system itself. Governance reform doesn't mean a massive change in the architecture of the system. It means the way in which the system is supervised, how leadership is appointed into these organizations, because nothing in any complex organization can function effectively if the leadership is compromised. You need strong people at the head of a hospital, a large, complex hospital. You need somebody above them to hold them account directly, not at a great distance. You need to not have members of the executive of government appointing any of these people. So just to make one point, I mean, noting sort of gift of the givers, the distinction between what I call knights and knaves in society is you don't design systems on the assumption that only knights will ever run it. They won't. That's why a system needs to structurally ensure that there is a way of getting good leaders into the key positions. That enables the full organization. We have a system that was designed on the basis that only knights would ever get appointed by politicians into the organization. What has actually happened is that all the knaves pushed out all the knights pretty quickly and made sure that they were in those positions, and they don't give a damn about service delivery. And that is a governance design issue. It's structural. It's not about teaching people ethics. These people are sociopaths. They don't care about ethics. You have to change the system so that people who actually have a belief and a desire to run these organizations ethically and appropriately are the only ones who ever end there, and that is a structural issue of how you appoint, remove, etc., and how you supervise. And it can't be done with members of the executive appointing networks and syndicates of people to basically syndicates of extraction into our public organizations. And this is not only our public hospitals, but it is most definitely all the way through our public services. So we need that to change. And in the private sector, we need to basically have the health market inquiry framework taken forward by a sophisticated group of people who can cope with that kind of report and take it forward. That, unfortunately, sadly, is not the Department of Health. So we will, on both scores, wait, because there's no political will to either allow the private sector to stabilize and succeed through regulatory reform, or to challenge the people who are basically part of quite sophisticated and extensive syndicates of extraction linked to politicians at the provincial level of government. Leave that in place. Our system will become dependent on people operating outside of the system, trying to palliate it. So we do have to look very carefully at our system going forward. We have to hold people to account. We can't allow this to continue. Our health system has the assets, it has the people to be a brilliant system. It has the resources. But it's how we put it all together as an organization and a system that will make the difference. And we're not there yet, but we basically, I would say, have to make sure that it is changed to be that. I'll leave it there.
Wow. I often find it hard to follow an economist's train of thought. Professor Alex, I've followed every last word that you spoke. And I want to say I've heard a lot of people speak on NHI. Thank you for taking the gloves off, for being pragmatic, for not pulling punches. I do feel like I've been punched in the gut. But thank you for just revealing the truth. I think possibly just in terms of next year's program, let's end with possibly Dr. Imtiaz Sooliman, and maybe start with Alex. No, let's give our Professor Alex van Heever a big round of applause. Thank you, Alex. That's, as they say, the truth hurts. Has that been up for a long time, by the way? Oh my word, can we change that? That's it. Thank you. I'm sure there are a couple of questions. I know we've come to the end of our evening. I know it's important that we get up and move. We do know that For every cigarette you smoke, you shorten life expectancy by 11 minutes. For every hour you sit, you shorten life expectancy by 22 minutes. It's a fascinating study, showed that sitting is the new smoking. So we want to move. But if there are some questions, now is the time to ask. I'm not going to ask our speakers to come up, but if you have a question, we've got some roving mics around the room. Just indicate who you'd like to ask the question to, or ask the question, and we'll give a mic to our relevant speakers. Are there any questions at this time of the evening? Just raise a hand, and we'll get a mic to you as soon as possible. Any questions? I don't see any. Oh, there's one right here. Wow. Sorry, looking right over you. Can we have a live mic in front? The MC's mic. There we go.
Thank you very much. I'm Raphael. My question is to Professor Alex van den Heever. You talked about tax. I was interested in that topic. You said you can't get more revenue by raising taxes. Can you get more revenue by cutting taxes?
Actually, when you're at tax capacity, theoretically you don't get more. You're at the top of that curve. So essentially you've maxed out. Now, if we were over the curve, you would get a reduction. A reduction in tax rates would actually increase government revenue. But every indication is that we're basically just at the top, at the ceiling. It's difficult to tell ultimately whether you're slightly below or above. And the other issue is that tax revenue varies at those tax rates based on economic growth. So it will move up and down. But essentially, I would say in South Africa, no, we probably won't get additional tax revenue from a tax cut.
Thank you, Alex. While both of you have the mic, Rajesh, Alex, maybe a question that I have for both of you. We understand that the NHI in its current proposed form is a non-starter. Is there a form in which the NHI could work? Because equality in healthcare is a noble cause. It's something we all need. So we have shot it down. Is there a form in which NHI could work? And there's a lot of you talk.
Yeah, so first of all, to look at the model that is proposed, and that is as a central purchaser who will supposedly improve performance in the health system through strategic purchases. So it's a monopoly purchaser. So the Department of Health objects to saying, well, look at Eskom, because that was a monopoly purchaser as well. But all monopolies suffer from the problem that they face no competition, they face no impact if they don't perform. They are basically immune to anybody dealing with them. And much like the way in which we see senior officials in government not being fired when they're crooks, that's a form of immunity. That's what happens in monopolies. There are no consequences to bad conduct, there are no consequences to bad performance. So the idea is actually a high-risk one, centralized purchaser. It makes sense to have social insurance funds. It makes sense to have regulated markets, properly regulated markets. It makes sense to have free public services under different authorities. But where you create a monopoly structure, like let's say a district health authority or a provincial health authority, their performance, because they face no competition, no threat, depends on the accountability systems that you introduce. They must face that threat. The politicians that misbehave must face the threat of being removed from office. So you've got all these layers of accountability that must knit for a public authority to be efficient. So we don't have the accountability structures in place at this point, and there are none proposed that are any different to the way in which our current public system functions, proposed for the way in which the National Health Insurance Fund would operate. Everybody there in the kitchen sink is appointed by the Minister of Health. The Office of Health Standards Compliance, which would theoretically do the accreditation of any healthcare provider who would then be permitted to contract with the National Health Insurance Fund, everybody in that organization is appointed by the Minister of Health. The Ombud, the Health Ombud, is appointed by the Minister of Health. So you're beginning to see a little bit of a pattern, which is for accountability systems to work, you require a separation of powers. Because if you don't have a separation of powers, in accountability structures, you have conflicts of interest. And what we have is an entire system designed to accentuate conflicts of interest, where the people in positions, supervisory positions, have a conflict of interest with the people who are running services. And under those circumstances, they have no desire or incentive or intention of holding anybody to account if they both are colluding. That's the problem.
So we talked about separation of church and state. You're saying separation of health and state is possibly where the solution lies.
Well, separation of powers in every structure is important when you're designing accountability, because the person holding you to account can't have a conflict of interest with the person they're holding to account. Yeah. That's the whole idea. We have a system which is designed with conflicts of interest all the way through it. And that all comes from having the executive of government being able to willy-nilly appoint and remove people within the administrations. This includes the state-owned enterprises and all the public organizations. That is a system designed to fail.
Prof, thank you very much. Rajesh.
Yeah, if I can add on that, the point is, if the health system is functioning the way we want it to function, then the solution is a multi-party, multi-funder system. And Alex talked about the whole competition issue. That's absolutely correct. The problem with the current bill, it's very poorly drafted. I'm not a lawyer, but when I read it, it seemed like a disaster. It's interesting that we have a Companies Act in South Africa. We have King 4 on corporate governance, and it's meant for all the private sector companies and many of the, some of the state entities which don't implement it. But it's not applicable to all these new creations. If you read this bill from a governance perspective, it doesn't even take the good out of the Companies Act and put it into this bill. It takes no cognizance of what King 4 recommends for good corporate governance. And like Alex says, it's literally everything. It's literally the minister is going to appoint everyone right down to the janitor in the institution. And obviously, if that's the kind of thing that takes place, no one is going to take accountability of doing any work.
And we won't let it get there.
Well, we need to throw this bill out and start from scratch. A good, reasonable NHI bill probably should be 8 to 10 pages maximum, about setting up the structure, what are its powers, what does it have to do, full stop, and the rest comes into regulations. It is possible, but yeah, you can't have a separation of finance from service provision. If the service provision is not working well, what services are you going to buy with it? Insurance, national insurance. So they should be focusing that effort on fixing the service provision and then start thinking of separating the finances with it.
Brilliant. Rajesh, thank you. Thank you, Alex.
Sorry, just one point on that, just to note that this idea of separating purchaser and provider is not a requirement to get a functional health system. You can have vertically integrated systems that are very, very efficient. Again, it just comes down to the governance design. It's not the purchaser-provider split. And there are so many flawed assumptions in this framework. Our provincial health departments, in terms of the broad architecture, are potentially extremely viable health authorities, with a few adjustments to remove conflicts of interest and introduce more decentralization in the system. Now, we can go there, that will work. Introducing centralization and procurement, which would be the biggest fund in South Africa with the levels of corruption that we have now, is clearly not going to correct anything.
No. The thought is terrifying. Any final questions? Guys, thank you. Thank you for those answers. Part of me was hoping that Dr. Aaron Motsoaledi was here this evening to hear some of this. Wouldn't that have been great? Guys, I think let's call it there. Before we wrap up, we have 2 prizes to give away. I have it here. Melomed Renal Care has got a hamper. They've randomly selected a winner. I don't know if you want to come up and hand over that hamper. Is Melomed here? Yes, they are. They randomly selected a winner, and that winner is Dr. Naila Kannemeyer. So if that's you, Naila, please join us on stage, collect your hamper, and let's give her a round of applause. There she is. That looks like a lovely hamper, Naila. Don't finish it all tonight. Yeah. And while Naila waits for a photograph, thank you very much to Melomed Renal Care. Intersure has got an espresso coffee machine they're giving away. I'm going to ask them to come up on stage to draw a winner from the box. There it is. Thank you very much. With an espresso coffee machine. According to Harvard, how many cups of coffee a day? You guys know this. I think I say this way too often. At least 6 cups of black coffee a day and you will live longer. I kid you not. And if it's an espresso, even more so. So there's a wheel. How do we spin the wheel? Do we just press a button? Guys, will you spin the wheel, please? Hope you can read that. In the month of September, Wendy September. Where are you, Wendy? Congratulations. Let's give her a round of applause. Thank you so very much. And sure, thank you. What a great project. Thank you so much, Intersure. What a wonderful, wonderful prize. Shaima is going to pop up and just hand over a hamper to our speakers. Let's give our speakers a big round of applause as we wrap up tonight. So thank you, Dr. Rajesh Patel, Dr. Imtiaz Sooliman, and Professor Alex van der Heever. So appreciate that. I think the hamper's actually coming to you, but thanks for coming up, Rajesh. That's great. And while they are getting their hampers, also a very special thank you to Melomed, I think, for hosting such an exquisite event. I mean, CPD event. This is not what CPD events should be and look like, but they do. Thank you to Melomed, an exquisite event. Thank you for the attention to detail. It really has been remarkable and a wonderful, wonderful experience. So to our host, Melomed, thank you very, very much. Let's give them a round of applause. Also to our guests, thank you for joining and sticking around tonight, for having these important conversations, for taking the time to attend. I hope you do leave with a renewed sense of hope and purpose and a lack of anxiousness or anxiety. I think what's been shared from the stage tonight has been really, really superb. And lastly, to our sponsors, thank you so much for your support. Tonight would not have been possible without your support. Let's give our sponsors a big round of applause. Thank you very, very much. It was the playwright George Bernard Shaw who didn't get on with Winston Churchill at the time and sent him 2 tickets to the opening night of his play with a note that said, "Sir Winston, I have 2 tickets to the opening night of my show for you and a friend if you have one." Churchill responded and said, "Mr. Shaw, thank you so very much. Can't make the opening night, but could have tickets to the second night if there is one." This won't be the first. It certainly won't be the last. So ladies and gentlemen, thank you for joining us for Melomed's CPD event tonight. We look forward to the next one. Have a great night.